So, Dr. Chami will go live in 5 seconds.
Not yet her. I've not been able to hear the voice yet. Very good evening, one and all, and warm welcome. We have gathered here to gain insight about a topic which is very important but yet less discussed, that is ventricular arrhythmias. As we all know, ischemic heart disease is important cause of ventricular arrhythmias, which leads to sudden cardiac death. In today's session, we have two experts to talk about refractory ventricular arrhythmias and role of Mexiletine in its management. I have the honor of welcoming and introducing our esteemed faculty. Our first esteemed speaker is Professor Dr. Joy M. Thomas, sir. Sir is senior consultant at Apollo Hospital, Chennai. Sir founded Tamil Nadu Electrophysiology Council in 2014 and led the Chennai Pediatric EP Symposium. Sir has also performed Tamil Nadu's first radio frequency ablation and first transapical aortic valve implant. Sir has been international faculty at prestigious TCT Asia Pacific World Congress of Arrhythmias and Asia Pacific Heart Rhythm Meets. Sir has also authored 57 articles, 7 textbook chapters, and is editor of the Indian Journal of Electrocardiology. We welcome Sir. We also have with us Professor Dr. Ketan Mehta, sir, as our esteemed speaker. Sir is senior consultant at Suchak Hospital, Health Harmony Clinic Care, Asian Heart Institute, Seven Hills Hospital, and Nanavati Hospital in Mumbai. Sir is Honorary General Secretary of Indian Society of Electrocardiology and is founder president of AAME and Accord. Sir is also editor board member of JAPI and Journal of Medical Nutrition and Nutraceuticals, and has been principal investigator for multiple major clinical trials like TIPS 3, HOPE 3, and MAS. With this, we welcome both our esteemed speaker, and without further ado, I hand over the session to our first speaker, Dr. Joy Thomas. Sir, over to you.
You are muted, sir. Please unmute.
Okay, yeah. uh, Keep forgetting these things. Good evening, one and all. Today we'll be discussing something on Mexiletine, a wonderful drug which has come to help us in managing refractory ventricular arrhythmias. And we'll also look at the mechanism of arrhythmia suppression in the with this particular drug. The I would first like to begin with a case study. This is a 68-year-old diabetic and hypertensive, which I treated a few years ago. This came to us with the dyspnea of grade 4 and angina on exertion for 3 months with worsening symptoms till he came recently when he came to us. He had bilateral pedal edema, orthopnea, and PND. He was tachycardic and BP was only 90/60. Biochemical parameters were normal, but troponin was positive. So we did an angiogram for him, and this was the ECG. As you can see, he had an ST depression in V3 to V6 in the lateral leads and an elevation of the ST in ABR, indicating that he has significant coronary artery disease. This is the angiogram. Uh, as you can see, there is a very tight stenosis in the distal part of the left main. In addition to that, he has also got diffuse disease of the other vessels. So this is the right coronary artery, the dominant vessel, and you can see the diffuse nature of the diffuse disease in the different parts of the vessel. So an angioplasty was done for him because he had left main and the patient was symptomatic with angina. He had a stent put in the left main and another one in the proximal LAD. And this is the result of the stenting after the stenting. You can see now the major blocks are removed and the good flow is established in the LAD. And the immediately after that, you can see the ST segment depression in V3, V4, V5, V6 lateral leads has suppressed, and the ST elevation in AVR has also uh, disappeared. So we thought we have done what is good for this patient, considering the coronary anatomy and the diffuse nature of his vessels. But we were disappointed because a day later, he started having short runs of VT. He was started treated with amiodarone IV bolus and IV infusion. The electrolytes were corrected, but he continued to have incessant VT. We were at a loss what to do. We gave him Xylacard, boluses, and whenever he had the VT, but he was had to be shocked at least 6 7 times during the second day, third day after the angioplasty. Then I decided to take him up for a electrophysiology study and radiofrequency ablation, what we called as scar mapping and substrate modification. Uh, Simultaneously, around the same time, in the evening, we started him on Mexiletine, and because of the poor response to lidocaine. And this is the angiogram, as you can see, the multipolar catheter being used to map the left ventricle by 3D mapping. And this is the figures of the 3D mapping. You can see the scar, the location of the scar in the left ventricle. Uh, One of the first things in EP study and radiofrequency ablation is to induce the tachycardia so that you can locate the tachycardia by studying the earliest site of activation of the ventricle. But we could not induce the tachycardia, and then finally we settled for substrate ablation. As you can see, the brown dots, which are the ablation being done to modify the ventricular substrate. The patient was an amiodarone and induction protocols done showed that there were no arrhythmias after that. So, refractory ventricular arrhythmias refer to ventricular arrhythmias that persist despite optimal medical therapy, catheter ablation, or ICD interventions. And there are three types of uh, ventricular arrhythmias. One is a ventricular tachycardia because of sustained VT, or this could be non-sustained VT when it is short and terminates on its own. And then there is a third set which is known as polymorphic VT. Then there is ventricular fibrillation, which is a disorganized electrical activity which leads to cardiac arrest. Electrical storm, by definition, is three or more VTVF episodes within 24 hours which require ICD shock or antiarrhythmic therapy. And our patient had more than six shocks delivered on one day. So he is a person with an electrical storm. So uh, looking at ventricular arrhythmias, in the first week of acute MI, there's a 12% incidence of ventricular tachycardia, and the mortality in such cases is about 50%. 2% of cases have ventricular fibrillation, and all of them die. In heart failure patients, non-sustained ventricular tachycardia occurs in 20 to 80% of cases. 50 to 60% of deaths in congestive heart failure are sudden and attributed often to ventricular tachycardia. So, life-threatening ventricular arrhythmias, including ventricular tachycardia, and ventricular fibrillation are responsible for most of the sudden death that we come across. Now, what is the epidemiology of ventricular arrhythmias? Well, if you look at the prevalence, they contribute significantly to sudden cardiac death and are responsible for 300,000 to 400 deaths annually globally. The patients with ischemic heart disease and cardiomyopathy have a 5 to 10% lifetime risk of developing sustained ventricular arrhythmias. And but if you look at the risk factors, who are the likely population who can have this? It is coronary artery disease, myocardial infarction, left ventricular dysfunction, and structural heart disease. Genetic predisposition in channelopathy uh, are another group. The examples are long QT syndrome and Brugada syndrome. And how do they impact the healthcare? Because of these ventricular arrhythmias, they come for frequent hospitalization because of ICD shocks or recurrent arrhythmias and the need for repeated ablation procedures. And this causes a substantial burden on the health finances because of long term antiarrhythmic drug therapy and device management, which is required for these patients. So, what are the challenges in arrhythmia management? ICDs have got their limitations. They reduce sudden cardiac death, but at a cost. They do not prevent recurrence. They lead to painful shocks, psychological distress, and device complication. So much so, some of the patients will beg you to remove the ICD from the body. They don't mind dying, but they can't bear the pain of the shock. Ablation challenges, recurrent VT due to incomplete ablation and deep mural arrhythmia, arrhythmogenic focus, which are inaccessible to standard technique, are challenges for the ablationist. Refractory electrical storm, multiple ICD shocks worsen the hemodynamic instability and increase mortality because with each shock, the myocardium suffers an injury, and this injury gradually contributes to the worsening of the uh, the dysfunction of the ventricles. There is a need for personalization, that is by genetic testing and novel pharmacological target and stereotactic radioablation. They offer emerging treatment avenues, which is something to look forward in the future. Now, look at the gamut of antiarrhythmic medications. As you know, the Vaughan and Williams classification has classified it into 4 plus 2. That is the group one are the sodium channel blockers, group two are the beta blockers, group three are the potassium channel blockers, group four are the calcium channel blockers. Then you have digoxin as a group 5, which increases vagal tone and affects the sodium potassium pump, and adenosine, which induces AV block. Now, we are interested in Mexiletine today, and our discussion is confined to Mexiletine, which has which is a 1B type of sodium channel blocker. What it does, it has an effect on the action potential duration by reducing the upstroke rate and the action potential duration. So, what the role of Mexiletine in refractory ventricular arrhythmias? It's a class 1B antiarrhythmic drug. It blocks the sodium channel, and thus reducing phase of depolarization. It shortens action potential duration, lowers the effective, effective refractory period, excuse me, increasing the ERP-APD ratio in Purkinje fibers. Regarding the pharmacokinetics, they are absorbed orally and they achieve a high bioavailability of approximately 90%. Peak plasma concentrations are attained rapidly within 2 to 3 hours after administration, and their volume of distribution is 5 to 7 liters per kg, indicating significant extravascular penetration. Moderate plasma protein binding primarily to albumin, with 50 to 60% of the drug is bound to the albumin. And looking at the mechanism of action, it is similar to lidocaine, often referred to as oral lidocaine. So what you see here is this is the action potential in a normal person, and in a person who has been placed on Mexiletine, what it does is the slope of the phase zero is slowed down so that you get a delayed rise to the top, and the action potential duration is also shortened compared to the normal one. So these are the two major effects, and they reduce the effective refractory period in Purkinje fibers. The reduction in effective refractory period is of lesser magnitude than the decrease in action potential duration, and this results in an increase in ERP by APD ratio. The sodium channel selectivity and action potential modulation. The action potential affects that shortens the APD with minimal QT prolongation. Now, no, please note this. The QT prolongation by Mexiletine is very, very minimal. Therefore, it reduces proarrhythmic risk effective in ischemic and depolarization tissues. This is what we want. And it has got a use-dependent blockade. That is, there is greater sodium channel inhibition at higher heart rates. So the faster the tachycardia, the Mexiletine is going to block sodium channel better. There is a huge dependent blockade. The greater sodium channel inhibition at higher heart rates enhances efficacy in VT and long QT3 situations. Electrophysiological impact, it suppresses abnormal automaticity, reduces ventricular ectopy, and mitigates electrical storms, often combined with amiodarone for refractory VT. So now this is a wonderful aspect about Mexilitine's role in ventricular arrhythmia management. Here we are able to use it as an adjunct to most of the commonly used arrhythmia. For example, if it is amiodarone which the patient is on, Mexilitine will help to reduce breakthrough VT episode and helps to manage recurrent VT or electrical storms in patients who have been earlier not responsive to amiodarone monotherapy. Amiodarone prolongs QT interval, increases the torsade disc as we saw in our patient, uh, but Mexiletine will counteract this excessive APD prolongation and therefore enhances cardiac safety. Flecainide and propafenone, if it is combined with flecainide and propafenone, it enhances antiarrhythmic efficacy in selected patients with refractory VT or premature ventricular contraction. And along with quinidine and disopyramide, it prevents excessive conduction slowing when used with class 1A agents. What about beta blockers? Yes, Mexiletine has a synergistic effect in VT management. Uh, because it's a class 1B sodium channel, it reduces excitability and suppresses and while beta blockers suppress sympathetic activity, reducing triggers for ventricular arrhythmias. So therefore, they complement each other. That had improved VT suppression. Studies suggest combined therapy significantly lowers ventricular tachycardia recurrence, particularly in ischemic cardiomyopathy. Mexiletine enhances beta blocker efficacy in suppressing premature ventricular contractions. And Mexiletine, along with beta blocker, helps in reducing ICD shocks. So they've been linked to fewer ICD interventions, thereby improving patient well-being. Uh, Mexiletine and beta blocker in beta environment is an indication for refractory VT. Uh, it's amiodarone sparing strategy because the combined use allows for lower amiodarone doses. Therefore, it reduces the adverse effects like thyroid dysfunction and pulmonary toxicity. It is effective in reducing VT episodes, and clinical data supports its role in reducing VT burden in ICD patients, particularly ischemic heart disease. The risk management requires ECG monitoring because we have to monitor the QRS prolongation. Because although it is minimal, there is still a QRS prolongation which can cause a proarrhythmic risk. So safety tolerability of Mexiletine-induced proarrhythmia and how to prevent them. The proarrhythmic potential, uh, it can cause QRS widening and exacerbate ventricular arrhythmias in susceptible patients. The risk is higher when the patient has severe structural heart disease and pre-existing. So what do we do? ECG has to be monitored for regular assessment for QRS prolongation. Number one, the dose adjustments initiate at a lower dose and titrate cautiously. Avoid concomitant QT prolonging drugs so that it prevents excessive repolarization disturbances. And electrolyte balance has to be maintained by monitoring and correcting hypokalemia, hypomagnesemia to reduce proarrhythmic risk. So, what about patients with the renal and hepatic dysfunction? In hepatic impairment, Mexiletine is primarily metabolized in the liver by cytochrome P1A2 and cytochrome P2D6. So, severe hepatic dysfunction increases drug accumulation. So, the dose reduction has to be done and extended dosing intervals. In a renal impairment patient, there is limited renal elimination. However, metabolites can accumulate in severe renal dysfunction. So, close monitoring is essential to avoid toxicity in these situations. Practical adjustment: when the hepatic impairment is mild, you reduce the dosage by 30 to 50%. In cases of severe hepatic dysfunction, we have to be cautious. We start with a low dose, 100 to 150 milligram twice daily, and titrate based on tolerability. Adverse effects are seen and requires monitoring guidelines. Common adverse effects in, neurologically, dizziness, tremors, ataxia, GI, nausea, vomiting, epigastric discomfort, cardiac, bradycardia, hypotension, conduction disturbances. And we already went through this ECG monitoring, liver function test, and neurological assessment, drug-drug interactions, uh, as cytochrome P1A2 inhibitors, which we can come across in clinical practice, are fluoxamine and ciprofloxacin. What they do is Mexitil levels will increase, increasing the toxicity. Cytochrome P1A2 inducers, that is rifampin and smoking, they reduce Mexitin levels and may require dose adjustments. So, what is the role of Mexiletine in the era of catheter ablation and ICD therapy? Mexiletine post-ablation in scar-related ventricular tachycardia, as we see in scar-related VT post-ablation, um, the VT ablation targets arrhythmiogenic circuits, but residual arrhythmia sources within the scar often persist, leading to recurrence. Post-ablation inflammatory changes can temporarily increase arrhythmia vulnerability, so you need antiarrhythmic support, and Mexiletine provides this support. Patients with extensive myocardial scarring, particularly post-MI or in structural cardiomyopathy, remain at high risk of VT recurrence despite ablation. The targeted sodium channel blockade, Mexiletine will suppress uh, because of the sodium channel blockade within scar tissue. It reduces the probability of re-entry arrhythmia formation. It's an adjunctive therapy to amiodarone. Combining with amiodarone enhances arrhythmia suppression, allowing for lower doses of amiodarone and thereby reducing long-term toxicity risk. Reduction in ICD shocks and VT burden. Studies suggest that adding Mexiletine post-ablation reduces VT recurrence rates and minimizes ICD intervention, improving patient quality of life. Bridging to long-term therapy, Mexiletine can serve as an interim stabilizing agent post-ablation while the scar remodeling process evolves and long-term treatment strategies are optimized. So, a study in patients with post-infarct VT has shown that Mexiletine addition post-ablation led to a significant reduction in VT episodes over 6 months and supporting its role in scar-related arrhythmia suppression. And therefore, the key takeaway is there is a critical role in post-ablation VT management for Mexiletine, particularly in patients with residual scar-related arrhythmogenic substrate by enhancing rhythm stability and also by reducing ICD shock. Now, how do we integrate Mexiletine in ICD therapy? Case-based insight. The challenge of recurrent VT in ICD patients. ICDs prevent sudden cardiac death, but do not suppress VT episode, leading to recurrent shocks, increased hospitalization, and reduced quality of life. Frequent ICD therapies are associated with worsening myocardial function, electrical trauma, and psychological distress. Many patients require antiarrhythmic drugs to suppress VT, but conventional options like amiodarone have long-term toxicity concerns. So, in ICD patients, Mexiletine provides effective VT suppression by inhibiting sodium channels in ischemic myocardium and suppresses recurrent VT, both appropriate and inappropriate ICD shocks are suppressed. In QT neutral profile, unlike the class 3 agents, for example, sotalol and dofetilide, Mexiletine does not prolong repolarization, making it a safer option in patients with structural heart disease who are at risk of TOS at this point. Combination therapy with beta blockers or amiodarone. When used alongside beta blockers, Mexiletine enhances arrhythmia suppression while avoiding excessive bradycardia. So, Mexiletine is a bridge therapy before can be a bridge therapy before catheter ablation when the patient while the patient is waiting for ablation and there are patient goes into a VT storm or multiple ventricular arrhythmia, electrical storm and hemodynamic instability in patients increase awaiting catheter ablation increase mortality risk if VT is left uncontrolled. Uh, Amiodarone, though effective, requires long loading period and significant systemic making it unsuitable here. Sedation or anesthesia risk during emergency ablation in unstable patient underscored the need for pharmacological VT suppression before the procedure, just as we did in our patient. So, Mexiletine as an effective therapy in ventricular arrhythmias, some important points and takeaway is immediate VT suppression can be achieved. Mexiletine rapidly reduces VT episodes, providing stability until definitive catheter ablation is performed. It's an alternative to high dose amiodarone. In patients unable to tolerate amiodarone, Mexiletine offers an effective QT-neutral antiarrhythmic option, and uh, sometimes it works better than amiodarone in this situation, as I've seen in 2 or 3 cases. Hemodynamic preservation. Unlike other sodium channel blockers, example flecainide, propafenone, Mexiletine has a lower risk of negative inotropic effect, making it safer in patients with the reduced ejection fraction. So thank you for your patient listening. Any questions we can be handled. Thank you.
Thank you, sir. So we will take the question after Professor Dr. Ketan Mehta sir's session. So now we will have a sir's session.
Okay.
Good evening, everybody. Would you stop sharing so I can, Dr. Thomas, will you? Uh, uh, yeah, let me share my slide. Okay, my slides are visible.
Yes, sir, it is visible.
Okay, thank you. Good evening to one and all. At the onset, would like to thank Macleods, my friend Akil, Dr. Chami, and of course Doc Mod, which is the partner for today's program, Sylvester especially. Today's webinar, which is a very interesting one, which something new which has of late come up again, and here we have discussed about Macleods. So I'm going to discuss about clinical strategies for managing refractory ventricular arrhythmias, role of Macleods. Dr. Joy Thomas has very nicely put up all initial introduction about Macleods, interesting case study, and where all positioning of this molecule, especially with the dosage and everything. But still, there are a lot of things which we need to look into it. And that, before I proceed further, a beautiful quote from Alvin Toffler, who states that the illiterate of the 21st century will not be those who cannot read and write, but those who cannot learn, unlearn, and relearn. And that's where we are all here. So many things to learn, relearn, and unlearn also. As said by Sir Richard Dole, death is inevitable, but premature death is not. And when we talk about sudden cardiac deaths or ventricular arrhythmias, we need to prevent it. So it is not always by ICDs, but we have options also. So now let's look at the management of refractory ventricular arrhythmias. How do we manage it? Acute management. So this is divided into various categories. For example, hemodynamically stable patients with idiopathic VT. Now, in this category, what we use it most often is IV beta blockers and non dihydropyridine calcium channel blockers. They are the first line treatments which we know it. The second category is hemodynamically stable patients with VT due to cardiac channelopathies, where IV beta blockers we know are the mainstay of therapy. And third category, patients with a long QT-induced stable VT, where IV magnesium and Macleods which are considered. And that is what we are going to specifically look into it. Now, this is a beautiful flow chart given by American College of Cardiology ACC and American Heart Association for management of ventricular tachycardia, and it is of utmost importance from a consulting physician and a clinical cardiologist point of view. So whenever they come across a sustained monomorphic VT, what needs to be stay first is whether the person is hemodynamically stable or unstable. That's the first question which needs to look into it. If there is a hemodynamic instability, nothing else but direct current cardioversion and ACLS protocols need to be followed. There is no question, you can't do anything else. The question comes, if there is a hemodynamic stability is there, then try to procure the complete 12 lead ECG, a brief history taking, and a quick physical evaluation. And you need to look at what could be the underlying etiology behind it. So we need to consider what is called as disease specific ventricular tachycardias. And then we need to look at it, that is there a structural heart disease. So suppose if we have a 2D echo which has been done in a recent past, that can give an idea. So if there is a structural heart disease is present, yes, so then cardioversion, which is a class 1 recommendation which is there. Then there is alternatively IV procainamide, which is a class 2A recommendation, and IV amiodarone or sotalol, which is class 2B recommendation. And then look at the result out of it, whether the VT has been terminated or no. If it is not terminated, then obviously you will go for cardioversion. You can't, for example, if you tried IV procainamide or IV amiodarone, and if no response, then obviously cardioversion which has to be tried out. Now if VT gets terminated with this therapy, then what next? Then therapy which is guided by what is the underlying heart disease, and then you need to take a call whether this patient needs catheter ablation or what. And of course, the when VT is not terminated, even with the cardioversion, which can also happen sometimes. So you need to go with with the sedation, anesthesia. You need to reassess anti-arrhythmic regimen. What are the other options, and can even try with the repeat cardioversion. Okay, now let's come back to the middle of this protocol. Now, if there is no structural heart disease, and then you need to look at the typical ECG morphology, whether is there looking like is there any idiopathic ventricular arrhythmias, and you need to look at verapamil sensitivity, where you will use verapamil, or there could be a outflow track VT where you will use beta blocker for the termination of VT. Okay, now at end of this, if it is effective, then of course, then you need to give a therapy to prevent recurrent. And obviously, either you can go for catheter ablation, which is a class 1 recommendation, or verapamil or beta blocker, which is class 2A recommendation. Now, over here, if there was no response to these drug therapies, then obviously again cardioversion, which remains as a class 1 indication. So you can see over here, at many of the time, you need to resort to cardioversion, but if there is a hemodynamic stability and if the facility is not available, you need to be well versed with the therapies which can be offered to your patients. Okay, now let's look at the treatment of recurrent ventricular arrhythmias in patients with underlying ischemic heart disease. So, if someone who has already ICD and has got a VT or VF having a recurrent arrhythmias, so you need to look into it whether it is a polymorphic VTVF or is it a sustained monomorphic VT. Okay, now first let's look at a sustained monomorphic VT where catheter ablation again as the first line therapy. This is a class 2B, but here you can give as a class 1 recommendation use of amiodarone or sotalol. And at the end of it, if arrhythmia not controlled, then you need to look at further whether it is a non-ischemic cardiomyopathy, then you need to resort to catheter ablation, or if IHD with frequent VT or VF storm, if it is there, then again catheter ablation would be the choice. So here, in fact, if you look at it, even if it is yes or no, in either case, you have catheter ablation would be the choice. But if it is yes, catheter ablation is a class 1 indication. If no, catheter ablation is a class 2A indication. Okay, let's look at the other side of the table. If the person has a polymorphic VT or VF, we need to consider is there any reversible cause and what we should be looking for. The drug and electrolytes induced to some extent, obviously Dr. Joy Thomas has already discussed, you need to treat for QT prolongation, whether it is due to a drug or electrolyte imbalance. You need to identify the drug and discontinue the offending medication and need to correct the electrolytes, especially potassium and magnesium, which are of utmost importance. Now, if it is due to ischemia and there is an ongoing ischemic injury, then obviously you need to revascularize, and that is again a class 1 indication. But if there is no reversible causes, then what? Then you have a choice or option between amiodarone, which remains as a class 1 indication, versus beta blocker or lidocaine, which will be class 2A indication. And then you need to see at the end whether arrhythmia is controlled or not. If not controlled, we need to identify what are the PVC triggers, and if you can identify, obviously catheter ablation which will be there. If not, then there is something called as autonomic modulation which can be offered. So this is a very simplified way what ACCNH is given for recurrent ventricular arrhythmias in a patient with underlying ischemic heart disease. Now let's look at long-term management. Now, after VT conversion, whatever you have offered, whether be it a cardioversion or be it a drug therapy, treatment, what next? You are not looking at just you have managed acute. Now you need to look at the long term. So treatment options vary based on symptom severity and the extent of structural heart disease, including antiarrhythmic medications, implantable cardioverter defibrillators, and catheter ablations. And sometimes combinations of these therapies are also used when structural heart disease is present. So you may have to try more than one therapy which needs to be offered to the patients. Now, what does the guideline says? So if you look at various guidelines, what does AHA says? That symptomatic non-sustained ventricular arrhythmias on an adequately dosed beta blocker or non-dihydropyridine calcium channel blockers, antiarrhythmic drugs such as amiodarone, flecainide, Macleods, propofenone, or sotalol may be considered. What does European Heart Rhythm Association says? They just categorically mentions that if it is a structural heart disease, and then you need to look for specific treatment of ventricular arrhythmias with antiarrhythmic drugs, again amiodarone, Macleods, or sotalol, catheter ablation, and or anti-tachycardia pacing from, of course, ICD, which can be considered. And even it has been suggested that Macleods is indicated in long QT3 patients with prolonged QT interval. So now we have got recommendations for all these societies, which has been clear cut mentions the specific drugs for its specific usage, and Macleods, which has been recommended in long QT3 patients with prolonged QT intervals. Now, what does Canadian Cardiovascular Society and Canadian Heart Rhythm Society mentions in their last position statement of 2020, where they mentions the suggested use of Macleods given in addition to amiodarone or dofetilide can be used in a patients with structural heart disease and refractory VT or VF who are not candidates in whom therapy with sotalol, amiodarone, or catheter ablation has failed. So now this is very important. We need to keep it in mind that everybody may not be fit for every option. There are people where you can't even allow further QT prolongation, which is a risk which remains with amiodarone, or there are patients who are not can go for catheter ablation. Now, remember a practical tip which is that Macleods has limited efficacy as monotherapy and ideally should be given in addition to amiodarone. Now let's look at clinical trials and real world evidence, because we always talk about evidence based medicine and we really need to look into it. There is a beautiful paper in Journal of Cardiovascular Disease Research about Macleods as a standalone antiarrhythmic agent for electrical storm and recurrent ventricular arrhythmias. Again, this paper comes from Tamil Nadu. Today, sir has already said Tamil Nadu always has been in forefront for whenever it comes to something innovative. And again, this beautiful paper which has come up from there. It's a prospective single-centric observational studies where maintenance dose 200 milligrams was given twice a day after adequate control of ventricular arrhythmias. The maximum dose we know can go up to 1200 milligram per day. Follow-up was for 12 months, so 1 long year it has been followed up. And what was found? There is a significant decrease in the total number of shocks which were be delivered and anti-tachycardia pacing which was there. So if you see, the VT-VF episodes were reduced drastically. Total shocks given had obviously become zero after the Macleods therapy, and total anti-tachycardia pacing also reduced drastically. So all the three numbers were statistically quite significant. Now, what does the long-term efficacy of Macleods with amiodarone? Now, this is the beautifully shown in the bar diagram that before Macleods and amiodarone and after the combination of Macleods and amiodarone. So Macleods combined with amiodarone significantly reduced VTVF episodes, also reduced total shocks and total anti-tachycardia pacing, all the interventions in a refractory ventricular arrhythmias. So at the end, we need to look at the survival and survival functions. Look at this chart. It is adding Macleods had no significant difference in terms of QRS complex, QT, corrected QT interval and a PR interval. So Macleods may be effective and safe in a patients with ICD and frequent ventricular arrhythmias and ICD shocks, regardless of the etiology of heart disease. So it has given, so it has been beautifully shown over here. So there is a significant survival benefits which has been shown. Again, a beautiful review article in European Society of Cardiology, Europe's effectiveness and safety of Macleods in patients at risk for recurrent ventricular arrhythmias. Here it is 8,000 odd patients, I would say rather 9,000 odd patients roughly were studied in 221 different trials. Ischemic heart disease patients were 72%, non-ischemic heart disease 14%, and primary arrhythmias 3%, with LQTS, long QTS diagnosis in 91%. So, what was found? Reduction in cardiac event burdens with Macleods. Look at this. PVC burden, over 80% reduction in PVC. VT burden, over 50% reduction in VT episodes. And VF occurrence, over 50% reduction in VF events. So, reasonably and significant impact it gives after starting the therapy. Now, Macleods on PVC separation, and these are data from various historical studies which is done across the globe. The number of patients in most of these studies were small studies. The duration of treatment was 2, and you had the dosage which was used right as low as 300 to 600 milligram to up to 600 to 1200 milligrams. And these are here what is that important to note, that these all studies has come long back. This is, if you see, almost 40 years old studies, and it has shown that the percentage of PVC reduction, which is definitely, and this is, is the placebo control crossover studies, active treatment crossover studies, and comparative parallel studies which is there. In parallel studies, Macleods versus quinidine which was studied, and what was found is more than 70% reduction with Macleods compared to 31% in quinidine. Now, control crossover where Macleods and disopyramide. So again, if you see the statistically significant number of PVC reduction which was found in Macleods, and of course with placebo control, that you definitely expect a huge reduction in the PVC which has been found when the Macleods was used also. This is again a beautiful EHRA systematic review about Macleods for recurrent ventricular tachycardia in adult patients with structural heart disease and implantable cardioverter defibrillator. Here there are 4 studies, 86% having ischemic cardiomyopathy, and Macleods plus minus amiodarone reduce the ICD therapies, especially when catheter ablation was unsuccessful or contraindicated. Now that's more important. We know that every patient can not have a success with the catheter ablation, or maybe even the procedure may be contraindicated. So Macleods is a viable long-term treatment option for recurrent or VT or VF patients with structural heart disease, especially with ICD, where ICD or catheter ablation was unsuccessful or unsuitable. Now, there's another trial where it has been shown that Macleods reduces serious ventricular arrhythmias post MI. So, incidence of, we know that ventricular arrhythmias are high post MI, especially in the anterior wall. Now, here it has shown that there is a significant reduction which is there compared to placebo. So, now, another paper, Macleods for ventricular arrhythmias in patients with chronic coronary syndrome, and this is a cohort study where 34 patients were analyzed with ischemic heart disease, and Macleods treatment, which was offered for almost 26 months, and to look at the for the Macleods treatment for refractory ventricular tachycardia or ventricular fibrillation, and this was over 10 years. So the Macleods therapy was associated with reduction of ventricular arrhythmias and ICD interventions in comparison with, of course, a matched time period without therapy. So obviously, when you look at VTVF episodes before and after treatment, which is significant, the VTVF episodes, ICD interventions, again, it had made a difference. So we know that Macleods has been an effective therapy over there. Oral Macleods for ventricular tachyarrhythmias treatment in implantable cardioverter defibrillator patients. Again, a systematic review of the literature. Here there are 4 studies accounting for total 91 patients retreated with oral Macleods. Amiodarone therapy was initially attempted in most of these patients, and catheter ablation was performed in one-third of patients. Now look at this data. So addition of Macleods led to approximately 40% reduction in number of patients with VTA recurrence from the period which was ranged from 8 to 26 months. Also, there is a reduction in number of patients with appropriate ICD therapies. So whether it is a shock or anti-tachycardia pacing by 30%, which is important. So it's not that once you have implanted or once you have put a ICD, if it goes on delivering shocks, I know your patients is going to become uncomfortable with it. So you need to look at alternatives for it. So remember, your ICDs are there to save your patient, but not for routine, suppressing the ventricular tachycardia over there. So the salient features out of it is that anti-arrhythmic effect of Macleods has been established in various controlled comparative trials, which has been used in placebo trials compared with quinidine, procainamide, disopyramide. It has been used at doses of 200 to 400 milligrams, can be used as a BID or TID dosage, which produce a significant reduction of ventricular premature beats and episodes of non-sustained ventricular tachycardia. And the follow-up of patients from the controlled trials have demonstrated continuous effectiveness of Macleods in long-term usage also. We have seen that. Now, what is most important is patient selection criteria and risk stratification. So, Macleods is primarily used for patients with life-threatening or symptomatic ventricular arrhythmias, especially in those who have failed with the conventional therapy. Certain inherited cardiac conditions. So for example, it is beneficial for long QT syndrome type 3, LQT3S 33, where it is the drug of choice, and of course, other sodium channelopathies. And what about adjunctive therapy? Often used along with amiodarone or beta blockers in refractory cases. So, in fact, it will have a definitely synergistic effect. Now, let's consider structural heart disease versus non-structural. So, in structural heart disease, it is often used in ischemic cardiomyopathy, post-MI, ventricular arrhythmias, or heart failure. Of course, it requires cautious use due to pro-arrhythmic risk. We know that all anti-arrhythmic agents are having a pro-arrhythmic properties, and it is best suited for patients with implantable cardioverter defibrillators to mitigate arrhythmia burden. And when we talk about non-structural heart disease, more commonly used in idiopathic ventricular arrhythmias like outflow tract tachycardia and inherited arrhythmia syndromes. It has a better safety profile due to the absence of scar-related conduction disturbances, which usually happens in a structural or a person with the previous MI. So, who is going to be benefit most when it is going to be used in refractory electrical storms? What are the high-risk populations? Patients with recurrent VT or VF despite standard antiarrhythmic therapy, ICD patients experiencing frequent shocks despite optimum medical therapy, mechanical benefits in electrical storm because it shortens action potential duration, which we have already learned. It stabilizes sodium channels, reducing excitability. It reduces VT recurrence when used adjunctively with amiodarone and demonstrates reduction in ICD shock in refractory patients. So, what are the key predictors of success? Combination with amiodarone with recurrent VT episodes, stable renal and hepatic function for optimal metabolism, and absence of severe conduction abnormalities when we talk about such things as high grade AV blocks. The dosage, which we already mentioned, it has to be started with the lower dosage, so it is 50 to 100 milligram increments can be done at 2 to 3 days interval. Loading dose can be given up to 400 milligram. The maintenance dose can be 150 to 300 milligram, and maximum dosage can go 1200 milligram per day. What about special population? Elderly, no dosage adjustment when the other parameters are normal. Renal impairment, as Dr. Joy Thomas already covered, no dosage adjustment in a mild to moderate renal impairment. And of course, we don't use it when the creatinine clearance goes below 30. For hepatic impairment, the caution is for mild to moderate because the metabolism is through liver, and a minimum of 2 weeks between dose adjustment is recommended, especially when there is a hepatic impairment is there. Precautionary consideration in severe renal or hepatic dysfunction, and for those who had a history of Macleods intolerance, which is a standard advice. Now, in patients with long QT syndrome and Brugada syndrome, for long QT, highly effective in type 3, reducing ventricular fibrillation by more than 90% in 98% of patients, and consistently shortens QT interval with more than 15% reduction in one third of cases. So it is recommended for type 2 and type 3 with high arrhythmic risk. What about Brugada syndrome? Minimal effects on heart rate, which also is an important point, and also on QRS duration, and it influences ST segment and QRS in Brugada patients also. So, friends, I would come to a beautiful quote from Sir Isaac Newton, that what we know is a drop, what we don't know is an ocean, and which is so much true when it comes to management of ventricular arrhythmias, and especially Macleods, which now we have got a wonderful weapon to take care of it. So thank you so much for your patient hearing, and would be happy to take up questions with my senior colleague. And before I end, I would say for my those colleagues who have joined from Maharashtra, there is a upcoming MMC election, and there is a which is happening on 3rd April, which is from morning 8 a.m. to 5 p.m. And we have Indian Medical Association Maharashtra State panel who is contesting for it. These are the 9 candidates. I am one of them. And please do come forward for voting. Those who are in Maharashtra, it would be at the district place. So that is my earnest request. And with this, I would end my talk and would take up the questions if there are any.
Thank you so much, sir. Thank you, Dr. Thomas, sir, and Dr. Mehta, sir. We have a few questions. So, one by one, I'll be putting the question to both of you. So, first question is something which was answered in your session, but multiple doctors have asked this question. So, for the benefit of all, if you could reiterate this question. So the question is, can Mexiletine be added over and above beta blockers in the management? Over to Dr. Thomas, sir.
Yeah, certainly it can be. In fact, we dealt at length about how it acts as an adjuvant to beta blocker therapy because the mechanism site of action is different. Beta blockers are anti-sympathetic and they belong to a different class of anti-arrhythmic agents, whereas mm, the mexiletine is a 1B, class 1B drug, and therefore they have a synergistic effect, and this can be utilized for this patient. Where the beta blockers have an anti-sympathetic role, and the Mexiletine blocks the sodium channel. These two integrate so that you get better results and effects in arrhythmia suppression.
Thank you, sir. Dr. Mehta, sir, anything, your take on the same?
No, rather what has shown over here in the both the presentations, because it will definitely have a good synergistic effect also, and it can definitely be very safely used. So if you see the category wise, it is comes in the anti-arrhythmic class 1B categories. So the drug where it will should not be used would be a lidocaine, which obviously you will not be using it simultaneously. But whereas the rather two common drugs which will be used along with maxilitine would be beta blockers and also the amiodarone. Thank you.
Thank you, sir. The second question is from Dr. Sharman. Dr. Sharman asks, what are the primary diagnostic challenges in identifying refractory ventricular arrhythmias? Dr. Ketan Mehta, sir, you would like to take it first?
Yeah, so basically there are challenges means it would come. There's in fact I have shown on the chart also. You need to go step by step, analyze it, and come to a conclusion, and you need to treat it. So at any given time, what is most important is, first is if the person is hemodynamically unstable or has got where you have to take a prompt action. So first and foremost is, if it is acute, you need to go and shock him. There is no question about it. And then this comes subsequently after you go on analyzing, find out if there are any correctable cause, and then you try, and if the patient, once the patient is stable, and then correctable cause. If it is not corrected by giving the therapy, it's not going to work for a long period of time. Because for example, somebody who has got an ongoing ischemia, and if you don't revascularize the patient, you have taken care for that particular time, and then that is subset of patients is going to have a recurrence of that ventricular tachycardia or ventricular fibrillation, ventricular storms. So, or for somebody who has got electrolyte imbalance, and if that is not taken care of, or there is a underlying drug which is ongoing and which causes the QT prolongation. We had rather one patient. Now, patient did not mention that he is under chest treatment. I mean, so quite often it happens. They said for chest we are going to some other doctor, and nowadays the trend is for COPD patients. Those again, for them ischemic heart disease is also common. Now the trend is for COPD, they are giving clarithromycin for a longer period of time, 6 weeks, 8 weeks therapy. Quite often, you have seen that one patient they had recommended 3 months. Now, during that time, if they develop, now all macrolides are notorious also. So, if they don't disclose it, and if that is ongoing, now they have got ischemic subset. They have got, you have taken care of ischemia, but the QT is not corrected because there is an underlying drug, and then it will behave like a refractory VT. So all this needs to be taken care of. By the way, can I ask Docmont to see? They are not allowing my camera to get on. I don't know what is wrong. So I think पर्दे के पीछे they want to keep me. So hope I am audible, but they are not somehow. It's saying that not been allowed from them.
You're
Anyway.
very handsome, boss. Now, I would like to add one thing. You raised a very important point, Dr. Ketan Mehta. See, that thing about clarithromycin, macrolide antibiotics is a very dangerous thing, because combine it with antihistamine like terpenadine and all that, and you have got a ticking time bomb, because they are very pro-arrhythmic. So therefore, we have to be very, very careful about the drugs that the patient is having. Very, very valid point. Yeah. Mm.
Yeah.
And the other thing is about ischemia. Ischemia has to be ruled out, because quite often we see patients post CAPG and all that, having arrhythmias and all in the post-operative period, day 3, day 4. And, yes, people tend to gloss over. No, no, everything all right. The surgery went very well. All the grafts are good. This is good, and ECG is all right. She is not showing ischemia. But sometimes when we do an angiogram, we see one of the branches are blocked, which if opened, maybe a diagonal or a large OM, we get over the ischemia and the arrhythmia. One of the most notorious is the right ventricular branch in the right coronary artery. Most people put a stent across the right coronary artery, I mean, across the right RV branch, so thinking, ignoring it. But that's a very important branch, and somehow that's a very arrhythmogenic area, the inferior wall in the coronary anatomy. Yeah.
Thank you so much, sir, for your insights. So the next question is from Dr. Sanjay. Dr. Sanjay asks, can Mexiletine be given safely in left ventricular dysfunction and HFrEF patients with ventricular arrhythmias? So over to you.
Uh,
I'll
can I
repeat.
answer
Yeah,
that?
so that's a
Yes,
very,
sir.
yeah, yeah. Yes, yes, sure, sir.
See, I think in my talk, this was clearly mentioned that Mexiletine does not depress uh, the ventricular function as some of the like beta blockers do and all that. So definitely is a wonderful drug to have on board. Uh, we make sure that every patient with LV dysfunction get a beta blocker, because you must have heard of the 4 pillars of heart failure management. Beta blockers, SGLT2 inhibitors, MRA antagonists, and then of course ARNI. So we always make sure that beta blockers are there. But the problem with beta blockers is they can depress the ventricular function, and the blood pressure can come down. And that itself, because it reduces the perfusion pressure, can lead to ischemia and arrhythmias. So these are problems with things. But Lexeritin does not. It does not have this problem of ventricular depression of the ventricular function. So definitely it can be used in patients who have ischemia and arrhythmias. It's a wonderful drug to have. Like I said, I have used it in several cases, and the problem was at that time, a few months back, was availability of Mexiletine. There was only one or two people who were marketing the drug, and suddenly it goes out of the market. We had a lot of problem, and patients used to call up at night and ask, "Doctor, you have written this drug. I'm not getting it. What to do?" This is the problem. But I think with Macleod coming now, forcefully, we hope the drug will be there. What, Dr. Akil?
Thank you.
Huh?
Thank you, sir. As you rightly says, we are taking care of availability, sir, across
Uh,
India. And
That's a
definitely
wonderful
we will
drug. I
take
would
it.
like to have it all the time around.
Sure, sir. Sure.
Yeah.
Can I
Yes.
add a thing? So what Dr. Thomas sir has said very rightly, it is rather the drug where you don't have to look about hemodynamics. That is one thing which is there, and quite often it happens. The patient with the ischemic substrate with LV dysfunction, there are so often their baseline BP remains at 90 systolic, and where they are on other drugs, for example sacubitril valsartan ARDNI therapy is going on, the beta blockers might be going on. Now if you need to give a long term therapy, and the drugs like amiodarone which can further have a negative chronotropy, for even for that matter beta blocker, so where this is the one drug which is absolutely safe, no hemodynamic compromise, you don't have to look and go for it. As sir has also pointed about the second point about availability, which I am now confident with Macleods coming in, we just have to, Dr. Chami, you have to give just number of Akil who everybody can note down, and then if availability is issue, he would see to it that it is being delivered easily over there, and I am sure it will be done over there. So it has really become a boon in the armamentarium of managing patients of refractory VT in our practice. Thank you.
I think
Thank you,
both
sir.
Dr. Akil and Dr. Sharmi will ensure that it is Amazon. Not amidon, sorry. Mexiletine is available
Mexiletine.
all the time for us. Yeah.
Yes, sir.
Then we have Dr. Keithan's video. I like to see his face,
Uh,
So I don't know.
Ritik.
It is showing that oops, something went wrong. Please close all browsers and rejoin the meeting. I will try to rejoin. That I will do it. Let me do that. Meanwhile, you can take one question. Yeah,
Yeah.
Yes, sir. Yes, sir. If
uh,
you can do that.
yeah.
So we'll continue. So next question is from Dr. Mahima. So this has been covered, but it would be beneficial if you would reiterate. So Dr. Mahima asks, what are the patient subsets clinically who will benefit from Mexiletine?
Patient subsets. Say anybody who's having ventricular arrhythmias, and we have been using amiodarone for quite a long time because that was available to us. And uh, apart from specific subset, for example, if a person has ischemic heart disease and arrhythmias, we always make sure beta blockers are there. And if a person does not have ischemia, then we go for amiodarone. And if there is no thyroid problems or other, QT prolongation or other thing in the ECG, initially in the baseline ECG, we avoid amiodarone, and those patients, we always try to go use some other drug. For example, we go for flecainide or we go for Mexiletine. So we had several drugs which we could use for these type of patients where the QT is a little longer than what we want. But uh, uh, now with Mexiletine, we don't have to worry about this. There's no problem about it. It has got only a minimal QT prolongation, and we can monitor it easily. So it is a drug that can be used in such patient. In fact, the fact that it can be used in long QT syndrome 3 itself is a wonderful thing that shows that will not long QT prolongation will not be affected badly by Mexiletine.
Yeah, here I would really say, sir, I'm sure, Thomas, sir, because we always come into dilemma, especially when it comes to arrhythmias in a patient with a long QTs, and then we are stuck, with the usage of medications, and either we are land up with, obviously, they are the one who goes for ICDs, or they are the one who goes for repeated shocks and all. But then once you have the Macleods, which is in terms of totally safe, there is no further QT prolongation, because that is one. In fact, there is some data which also shows to some extent it has some reduction in the QT also, which has been shown. So that would also be a beneficial. So I'm sure with uh, the long QT type 2 and type 3, this would be absolutely boon whenever we see such patients also. Yeah.
Quite true. Quite true. Right.
Thank
Good. Nice to see you back.
Yeah, sir. Thank you.
you. So we'll take the last question now from Dr. Ajay. Dr. Ajay asks, post-catheter ablation for refractory arrhythmias, how many patients need maintenance antiarrhythmics? How to choose antiarrhythmic agents in this patient? So, Dr. Thomas, sir, if you could.
I'm speaking for myself, and I think most of us do it. Even after an ablation for a ventricular arrhythmia, we are not very sure that the arrhythmia won't come back for various reasons. One is when we are ablating in the endocardium, that is within the ventricular cavity, and the God has created things in such a way, the heart in such a way that all these conduction things are in the subendocardial layer. So that is why we are able to map. That is why we are able to ablate, because the radio frequency energy goes only 2 to 3 millimeters, whereas your myocardium, left ventricular myocardium, is about 10 to 11 millimeters thick. So in this 10 to 11 millimeters, if you are going to put radio frequency and if it's going to touch only the one to two thing, you will not be able to create if your substrate is deep, sitting 5 centimeters, 5 millimeters. We're talking about millimeters, 5 millimeters inside. But thankfully, most of it, the conduction tissue is the Purkinje and all that is in the subendocardium, and therefore they are amenable for radiofrequency ablation. There are, of course, what are called as these cardiomyopathies, so South African trypanosomiasis and all those, where the entire myocardium is involved. You get a scar from endocardium to epicardium. Those we can't do by radiofrequency ablation. There we need epicardial ablation and many other things. But fortunately, in our country, we don't get many of those cases. Sarcoidosis is one such things, and uh, we manage that mainly by arrhythmic drugs like Mexiletine, amiodarone, and all those things. Of course, beta blockers also. So beta blockers still remain one of the primary things, and I'm glad that we discussed this thing about adding Mexiletine to beta blocker to make beta blocker more effective. It's a wonderful concept, and that should. I hope that has gone into people who have heard these talks in this session.
Thank you, sir. Dr. Ketan Mehta, sir, anything you would like to add further?
No, I would just say that Macleods, after it is re-emerging and has really become a boon for refractory VTVF for a long-term therapy. And the one thing which is there being an oral drug, we would be able to use it more widely. And there are so many patients who cannot go for the procedure for be it a catheter ablation, or there are patients who cannot go for ICD also. Now for them this is really going to be a boon, and I'm sure which will help our so many of patients with the refractory VT or VF. Thank you.
Thank you, sir. Thank you, Dr. Thomas, sir, and Dr. Ketan Mehta, sir. At this point, we come to end of our session. So truly, we had an academic feast. It was an enlightening talk and discussion, and we are sure that the doctors who have joined in here, it would benefit everyone. And we also thank our audience for taking out their valuable time for this academic session. And truly, it was wonderful. Even when we look at the feedbacks in the question link, everyone enjoyed this session and everyone learned a lot from the session. And we, last but not the least, we also thank our technology partners, DocMode, for their aid in arranging this program. So thank you, everyone, and a very good night. Thank you, sir.
And
Ask,
thank you.
ask Chami, ask everyone to join for the virtual dinner.
Yes.
Akhil
Yeah,
has
sure, sir.
arranged it.
Hello, sir. I am Akil
Virtually.
from marketing team from Macleods, sir. Thank you so much, sir, to Ketan Mehta, sir, and Dr. Thomas, Joy Thomas, sir. I'd just like to share, sir, across India, more than 2,000 people are was live. And believe me, sir, we have given clear instruction ki like this Mexiletine. The topic is on arrhythmia. So only cardiologist should be on board and in the login. So we have shared this only with the cardiologist. So across
Yes.
India, we got more than 2,000 login and people are live watching you, sir. And thank you for your great insight for the on the molecule and therapy, what you have shared. Thank you
Thank you.
from
Thank you
Macleod.
very much, Dr. Sharbi, Dr. Lucky, and Doc Mode, Dr. Sylvester.
Yeah.
And I would be failing in my duty if I don't thank my good friend, Dr. Ketan Mehta, who brought me in on this.
Thank you, sir. Thank
Thank
you.
you so
Bye
much.
bye.
Thank
Good
you all.
night.
And
Thank
thanks
you,
to all the
everyone.
listeners for patiently listening to us.
Yes.
Thank
Thank
you.
you. Bye
Thank you.
bye. Good
You,
night.
sir. Thank you for your
Thank you.
valuable time.
Yeah.
Thank you.
Okay.